Hi, everyone, and Happy New Year. On behalf of the National Alliance for HIV Education and Workforce Development, we would like to welcome and thank you for joining us on our monthly webinar series. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Ashley has added the questions in. Today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find the resource and to view the past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speakers will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open your line to speak. That's just some background on NAHU. NAHU is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. Established in 2010, NAHU supports the ATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, also known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events and trainings, learn about ORN work groups addressing health disparities, and more. So we will also include, so for today's session, we are accredited to provide CME, nursing CEs, social work CEs, and as well as a certificate of attendance. We ask that you please complete the post-evaluation survey that will be emailed to you after today's session. You'll get that in the post-webinar email tomorrow. We do ask that you complete it within 2 weeks of the session. And your feedback is very important to us. We use that feedback to help us inform us of the next sessions and topics that we should be addressing. We also share that feedback with our speakers, so I know they would appreciate it as well. But also we do ask that if you are requesting CEs that you do complete the evaluation. The certificates will be emailed within 3 weeks of completing the evaluation, and CE credits issued for participation in CE activity may not apply towards license renewal in all states, so please just check with your board. So at this time, I'm very happy to introduce today's speakers, Dr. Tara Prasad and Dr. Samantha Rollins Pilgrim. Dr. Prasad is the dental director at Boston Healthcare for the Homeless. She's an adjunct clinical faculty member at Tufts and UNE Schools of Dental Medicine. She received her DMD and certificate in dental public health leadership from the University of New England College of Dental Medicine. She is also currently obtaining an MPH in health policy at the Harvard T.H. Chan School of Public Health. Dr. Rollins Pilgrims is the Director of Population Health at BHCAP and an Assistant Professor of Medicine at Boston University Chapanian and Avedisian School of Medicine. I apologize, I may not have said that all correctly, but she is dually board certified in internal medicine and public health and general preventative medicine and certified as an HIV specialist by the American Academy of HIV Medicine. Her clinical and research interests are in primary care for underserved populations, as well as HIV/AIDS care and prevention. So at this time, I'm very happy to pass along to our speakers, starting with Dr. Rollins Pilgrim.
Okay, thank you very much. My name, as was said, is Samantha Rollins Pilgrim, and my colleague Dr. Tara Prasad and I are going to be presenting today on substance use disorders and oral health. And I we'll just say that we are both getting over cold, so we'll try our best to not be coughing too much. We don't have anything to disclose, but we will be discussing some off-label treatments. These are our learning objectives, which I will not read through in the interest of time, but you've seen them before and will be on the slides that are distributed later. So I'm going to start with an overview of substance use disorder trends and how substance use disorders intersect with HIV incidence. And this is a big topic. It could be its own presentation, but I'll cover just a piece of it. So I want to start with a definition so that we're all on the same page. This is from SAMHSA, the Substance Abuse and Mental Health Services Administration. So substance use disorders occur when the recurrent use of alcohol and/or drugs causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. So I want to first briefly talk about what substances are being used the most. So this data comes from the Millennium Health Signals Report, Volume 4, and it's data from the urine toxicology screens that are collected in substance use disorder treatment settings, and just looking at what substances were positive on these screens. So this doesn't give us information certainly about all of the substances that people are using, and certainly not everyone who's using substances is getting tox screens in the first place or in a substance use disorder treatment program. But acknowledging these limitations, it gives us a look at what substances are being used over time in the US. So looking at the graph, we see methamphetamine as the blue line at the top, well, at the top towards the end. Fentanyl is the black line, cocaine is the orange line, and heroin is the yellow line. And we see that between 2015 and 2021, methamphetamine and fentanyl use both increased, while cocaine use stayed about the same and heroin use decreased. And I'm going to speak mostly about opioid use, despite how much methamphetamine is used, or how frequently methamphetamine is used, how commonly it's used, due to the opioid epidemic that we've all heard about. The fact that in 2021, 220 people died every single day in the US from an opioid overdose. And so almost 645,000 people have died from opioid overdoses between 1999 and 2020. This graph is showing the trends in opioid overdose deaths by type of opioid used in the form of a graph. So here, this gray line at the top is overdose death from any opioid, or when any opioid was used. This this sort of teal line is commonly prescribed prescription opioids. This darker blue is heroin, and this purple one is synthetic opioids. And by synthetic opioids, we really are talking about fentanyl. So this can be broken down into 3 waves of opioid overdose deaths. The first was in the 1990s, which was driven by a rise in prescription opioid use. The second wave started in 2010 with an increase in heroin overdose deaths. And then the third wave started in 2013 with the increase in synthetic opioid overdose deaths as fentanyl really came on the scene more. You can see that this increase with this third wave really took off, and that the deaths overall increased as following this synthetic opioid deaths. And as we know, injection drug use is one of the main ways that substance use disorders and HIV intersect. So this is data from the CDC looking at HIV incidence among people who inject drugs. 8% of new HIV infections in the US in 2021 were among people who injected drugs. And as you can see, this number is remaining about stable over the past 5 years. And so we're not seeing a decrease in new HIV infections among people who inject drugs. And the next 2 slides focus on data from Massachusetts, where Dr. Prasad and I work. And these are from the Massachusetts Department of Public Health. And so this slide is looking at HIV incidence by the exposure mode, so the risk factor that someone had for being exposed to HIV. This top solid blue line is men who have sex with men. This dark dot and dash blue line is people who didn't have a known risk factor. The red dotted line is heterosexual sex. The purple solid line is presumed heterosexual transmission, and the solid red is injection drug use, and this green is people who or men who have sex with men and injected drugs. And so the key takeaway they have here is that after declining in 2000 from 2011 to 2014, almost in half, the number of reported cases of HIV with injection drug use as the primary exposure mode peaked in 2017 at 116 and then decreased to 59 in 2019 and then increased again to 76 in 2020. So while, as we can see here, certainly injection drug use is not the main exposure mode to HIV in Massachusetts, there have been multiple increases, and there have been different clusters of HIV among people who inject drugs in northeastern Massachusetts. And here we're looking at the number of individuals diagnosed with HIV who had injection drug use as an exposure mode by race and ethnicity and by year of diagnosis. And largely seeing that the number of this increase that we've seen more recently was mostly among white people who are shown here in this blue line who injected drugs, and less of a change among Blacks or Black people, but what have been some increases and decreases among people who were Hispanic or Latino. And then this is looking at deaths among people with HIV broken down by their exposure mode to HIV. So people who had injection drug use as an exposure mode accounted for the largest proportion of deaths among individuals with HIV in Massachusetts. In 2020, 32% of deaths among individuals with HIV were among individuals who reported injection drug use as their mode of exposure. And there were an additional 5% who reported being a man who had sex with men, as well as injection drug use as their risk of exposure. And so this is compared to smaller numbers of the overall people living with HIV with those exposure modes. So only 17% of the overall people living with HIV had injection drug use as an exposure mode compared to the 32% of those who had died, and 5% were MSM and also reported injection drug use compared to, well, the 5% is the same actually. So that's, never mind that part. I'm going to zoom in a little bit more to where we work. For those of you who are familiar with Massachusetts or Boston, you've likely heard of Mass and Cass. And so that refers to the intersection that's shown here on this map that's on the edge of the South End and Roxbury, which are two neighborhoods in Boston. And for those of you who are not familiar, this is an area with a lot of substance use, a tent encampment that's been broken down by the city on several occasions, including quite recently. So there actually is not a tent encampment right now because it was broken down recently, and a lot of extreme poverty and mental illness. And if you search for Mass and Cass on the Boston Globe website, you get 491 results from the last few years about substance use disorder, mental health, violence, deaths, and etc. And I want to mention also that one of the things that doesn't always get as much discussion that's happened in the Mass and Cass area is a cluster of HIV among people who inject drugs in this area. And so this is data again from the Massachusetts Department of Public Health looking at the cluster of people diagnosed with HIV between 2018 and early 2021. Who injected drugs. And so looking here, these blue bars show how many people were newly diagnosed with HIV per month, looking at this y-axis on the left. And then this orange line is tracking the cumulative number of cases in the cluster, with this y-axis on the right showing that total number. So seeing by month, starting in October 2018, through February 2021, new cases every month, and sometimes several new cases, up to 10 in January of 2020, with this total cluster coming up to almost 120 people. So I've given you a lot of kind of broad overview data, but I do want to tell you briefly about one patient in particular who I took care of in this area. So this was a gentleman who I met shortly after he had left incarceration. And he had been diagnosed with HIV right before becoming incarcerated, but hadn't really been able to connect with HIV care before his incarceration. Was treated while he was incarcerated, and then immediately upon being released, came to our clinic to get engaged in care both for HIV and for his substance use disorder. And he was taking his HIV medication and was kind of on and off buprenorphine for opioid use disorder treatment. He was really interested in treatment, but wasn't always able to take the medication. So I saw him in clinic pretty frequently, and I'd also tend to run into him on the street, and we'd chat about how he was doing. But he was also someone who would ask me about how I was doing. And then 6 weeks after I met him, he died from an opioid overdose. And he's not alone here. So the study from the Massachusetts Department of Public Health showed that the risk of overdose death was increased 120 times above that in the general population for people who have been recently incarcerated. And it's mostly in the first weeks after release. And this is because people, or largely because people have little to no access to opioids while they're incarcerated. And so their tolerance decreases significantly. And when they leave incarceration, if they use the same amount of fentanyl as they may have been using before, something that their body previously tolerated and would not cause an overdose now can lead to a fatal overdose. But we can do something about this, right? So I'll talk some about medications for opioid use disorder now. So we have three main medications that we can use. The first is methadone. Methadone binds to the opioid receptor, the same receptor that it's bound to by any other opioid, so any prescription opioid, heroin, anything like that. And it binds to this receptor and activates it. So people do pretty well with this. It's nice because you can increase the dose to any dose. There's no maximum dose or ceiling. And so maybe best for people with higher dose habits. And people are retained in care well. However, it's extremely inconvenient to get because people have to go into a clinic every single day. And treatment is largely dominated by for-profit, high-volume providers, and it's not very patient-centered often. Naltrexone blocks the opioid receptor. So it blocks this button and stops opioids from getting to the receptor. It has been shown to be inferior to buprenorphine, which is the next one that I'll talk about in intention to treat analysis because of the high dropout prior to the start. But once it started, addiction outcomes are similar. One thing that we worry about, though, is the lower tolerance that people may have and then risk for overdose if they stop using naltrexone. Excuse me. So meaning because naltrexone is not activating this receptor, it's just blocking the receptor, people lose their tolerance in the same way that we talked about for people who are incarcerated and not using opioids. But while they're taking naltrexone, the receptor is blocked, and so it decreases the risk for overdose. But if someone stops naltrexone, they now aren't blocking that receptor and have a lower tolerance, so are still at high risk for overdose. And then buprenorphine acts as a partial agonist, so it binds to the receptor, but not quite as strongly, or it doesn't activate it as strongly as methadone and other opioids do. And so people have equivalent addiction outcomes to methadone among people who are continuing, but retention may be a little bit less. It's much more accessible. It can be given in, a primary care clinic and various other places. And so this can make it, as I said, much more accessible, much easier for people to get, but also can mean that sometimes people sort of drop in and out of care. And there's been shown to be a 50% mortality reduction among people who have had an overdose and then start buprenorphine or methadone in Massachusetts. And the mortality effect is unclear for naltrexone. And then the last thing I want to mention is that even for those of you who are not prescribers, won't be in the position to be prescribing medications for substance use disorders, there's still something we can do to help to prevent opioid overdose deaths. And so one of those things is the main thing is carrying Narcan or naloxone, which is a nasal spray that can be given to reverse an opioid overdose. So you can get this, learn how to use it, carry it with you, and also talk with your friends, family members, patients, and clients about doing the same, because really it takes a lot of us out there who are able to reverse an overdose to keep people from dying. So thank you, and I will turn it over to Dr. Prasad now.
Dr. Prasad, please unmute yourself.
Hello, are you able to see my screen? Okay, great. Hi, everyone. My name is Kar Prasad. I'm a general dentist. I'm the dental director here at BHCHP. Thank you for the opportunity to speak with you all today. Dr. Rollins program and I are really appreciative of your interest in our presentation topic. So first, just a quick overview about my presentation. I'll share a few notes about oral health and homelessness, oral health implications of substance use disorders and medication-assisted treatment, oral health manifestations of HIV, and opportunities for medical and dental providers to address patient needs. Okay, so this is a photo of BHCHP's main location. So just as Dr. Rollins-Pilgrim mentioned, we're located in the south end of Boston, really kind of in the epicenter of Boston's opioid epidemic that you may have heard of. This is our main location. It's a building that houses adult primary care, behavioral health, a sedation monitoring program, our dental clinic, a pharmacy, and our medical respite program. In our dental clinic, we've been located here since the building opened in 2008. We see about 3,000 unique adult patients each year. And we are also a clinical externship site for 4 New England dental schools. And I'll just share that our adult patients really have a wide range of homeless experience. They can include patients who are recently evicted from their apartments because of soaring rent prices and are newly homeless, those who are staying on the streets or in a shelter for many years, those who have been in supportive housing, in and out for several years, and really everything in between. This is a photo of one of our 6 dental laboratories. So we are a comprehensive dental clinic. We offer preventative care, oral hygiene, oral health instructions, periodontal treatment, emergency treatment, restorations, oral surgery, dentures, and case management and care coordination. I'll add that we're hopeful to add digital dentistry and crown services given the recent Mass Health, which is Massachusetts Medicaid program, expansion of services in 2022. And I'll share also that our patients are covered typically under Mass Health or a handful of other dental insurances. So we are not a free dental clinic, and we do bill for the services that we provide. Okay. This got a little so a few notes about oral health and homelessness. So there is a high prevalence of untreated disease amongst people who are experiencing homelessness. Higher incidence of cavities, higher incidence of periodontal disease, early tooth loss, and unaddressed oral pain compared to the general population. There was one study that found that 72% of homeless patients had a history of tooth loss compared to 54% in the general public. And for the general public, that tooth loss typically was wisdom tooth extraction. A survey of about 200 homeless individuals in Oakland, California, found that 55% of participants in the study had unaddressed oral pain in the past 6 months. And part of the issue is disease conditions are often more severe by the time they're diagnosed by a dental professional. And this can be because patients experience significant barriers to accessing dental care. And there's several reasons why. So the first is patients are often have concurrent medical or behavioral health issues, and they have competing priorities. So if you can imagine, if a homeless patient is concerned about securing a bed at night, taking care of their mouth or going to see the dentist, understandably can fall lower on the priority list. There's also a lack of access to consistent and adequate nutrition. There can be a lack of access to a consistent place to maintain oral hygiene practices like brushing your teeth. There's also fear and apprehension that many patients have, especially for patients who have a history of PTSD or negative prior dental experiences. And there's also a shortage of dentists who are practicing in areas that are underserved and in areas where we have homeless experienced patients. Okay. So I wanted to just share this quote from a BHCHE patient because I think it puts into perspective how important dental care can be for patients in their journey with substance use remission. So the quote said, "I have been doing drugs since the age of 15. It wasn't until I got my dental issues addressed that things began to change. It helped my self-esteem and gave me a sense of confidence. Now I have a job and no longer homeless and am back in my family's life." Okay, so now we'll talk about oral health implications of substance use disorders and medication-assisted treatments. So, I'm sorry, I'm not sure why my screen kind of moves a little bit. Hopefully it'll stay there. So from this chart, we can see substance use can negatively affect oral health by inducing several oral facial conditions. They commonly include xerostomia, which is dry mouth, caries, periodontal disease. And when I say caries, that's the other word for cavities. Periodontal disease, bruxism, or clenching or grinding of the jaw, and precancerous lesions. This is often compounded by limited oral hygiene practices and psychosocial issues when patients are in active substance use. So the four that I'll go through with just some case examples are methamphetamine, cocaine, cannabis, and opioids. And as we'll see later, there are some similarities between the oral health effects of substance use and HIV. So first, this is a series of case photos and a panoramic x-ray for a 27-year-old male patient with a several-year history of methamphetamine use. So meth can be ingested, it can be smoked through a pipe, injected and snorted. But those who are at highest risk for the harmful oral health effects are those who ingest or smoke the drug. But harmful oral health effects have been seen really across all modes of meth use. Meth-related tooth decay, which you may have colloquially heard referred to as meth mouth, does have similar presentations to early childhood caries, also known as ECC. These types of cavities are usually the ones that are in between the teeth and also on the facial or buccal surfaces, like the front surfaces of teeth, especially in the front part of the mouth. This presentation gives these teeth the stained, kind of crumbling appearance that can happen at a very rapid rate. And the meth-related tooth decay is thought to be caused by several factors. The first is the acidic nature of the drug. The drug also causes xerostomia or dry mouth. And dry mouth, you'll see, is kind of a trend with these substances, is a really big problem for the mouth because it reduces the amount of protective saliva that's coating the teeth. There also can be drug-induced cravings for sugary and carbonated drinks, as well as caloric foods. There is a tendency for patients who are using methamphetamine to also clench and grind their teeth, which is especially harmful when the teeth are already in their decayed state, so that it can accelerate the rate at which the clinical crowns of the teeth can break off. The duration of the drug's effect is also quite long, which is about 12 hours compared to a shorter duration of about 60 to 90 minutes for cocaine. So this can elongate the periods of time when users are also not likely to be actively cleaning their teeth or maintaining oral hygiene practices. And so in this example, you can see this is a young patient, 27-year-old, but they present with a severely collapsed vertical dimension of occlusion because of this combination of cavities and the bruxism, or the grinding of the teeth. Okay. So next, these are the oral health effects of cocaine, particularly crack cocaine. These are a few intraoral photos from different patients and kind of resulting lesions from use of cocaine. So cocaine is most commonly snorted, but it can also be smoked in the form of crack cocaine and applied topically to gum tissue. Oral use of cocaine can temporarily numb the lips and the gums, and this can cause gingival or mucosal erosions or kind of chemical burns. And this is what you're seeing on the top and bottom right photos. So the top right photo is a traumatic kind of chemical lesion right at the mucogingival junction in the lower front part of the mouth. And the bottom right photo is a chemical lesion on the outer lip. This can also happen if patients are kind of testing their product. The top left photo is cocaine-induced keratosis of attached gum tissue. This is from repeatedly rubbing cocaine on gum tissue in this area. And the bottom left photo is an example of kind of a narrow recession or a bony dehiscence, loss of bone in the lower anterior area from smoking crack cocaine. Multiple studies have shown positive associations between cocaine use and periodontal disease. Bruxism, so clenching and grinding, and TMJ discomfort have also been noted, as well as cervical abrasion from in patients who kind of exhibit hyperactive toothbrushing activity. So cervical abrasion can be caused by aggressive toothbrushing right at the gum line, which can lead to a specific pattern of tooth loss. I haven't included a photo of this, but nasal and palatal perforations have also been described in patients who snort cocaine. This can cause serious speech impairments as well as challenges with eating and drinking. Next, these are some oral health effects of cannabis use. So these are some photos and two intraoral PAs of a 23-year-old female patient who reported a 3-year history of smoking cannabis in the form of unfiltered cigarettes. These cigarettes were placed in the lower front part of the patient's mouth for prolonged periods of time. So in the top photos, you can kind of see there's some inflammation of the gums. And also in the periapical, the image D, there is some localized severe and chronic periodontitis or breakdown of the bone that we see. And literature has shown that frequent and long-term smoking of cannabis can be quite harmful for gums and also the supportive structures of teeth, which we call the periodontium. Periodontal issues, especially amongst young patients, has become a more common and alarming finding for cannabis smokers, especially given the increased availability of cannabis and smoking products. Frequent cannabis users may also experience increased cravings for sweet and acidic foods, especially in the evening time. This particular patient was encouraged to stop smoking, which she did, and she underwent scaling and root planing, which is a periodontal treatment completed at a dentist's office, as well as a localized osseous surgery. And we can see the follow-up photos after 6 months in the photo C and the X-ray E, which does show improved clinical and radiographic results. So that's promising. And just one additional mention about kind of oral health and cannabis is there has been some conversation about the efficacy of local anesthetics used in a dental office in chronic marijuana users. There was a pilot study that was published in 2022 by the American Dental Society for Anesthesiology, and they found that there was no statistically significant difference in the efficacy of local anesthetics, such as lidocaine and articaine, between chronic marijuana users and non-users, but further studies are kind of needed to confirm these findings. Next, these are kind of the oral health effects of opioids, specifically heroin. These photos and x-rays are from a 46-year-old male patient who had a 23-year history of IV heroin use. And by the time this patient connected with this dentist and had this initial evaluation, The patient was on medication-assisted treatment, about 105 milligrams of methadone daily for several years. So opioids, include heroin, fentanyl, and prescribed opioid pain medications. Can be ingested, they can be smoked, they can be injected, and they can also be snorted. Opioid related tooth decay is thought to be caused by several factors. So one of them is salivary hypofunction, which can lead again to xerostomia, which reduces the amount of protective saliva around the teeth, which can accelerate cavity progression, and also some taste impairment, as well as periodontal disease. This is compounded by kind of inadequate oral hygiene practices, poor diet. And in this example, you can see from the pictures and from the x-rays, there's kind of this pattern of horizontal bone loss, furcation involvement of the molar teeth, and kind of wrapping cavities right around the gum line of the upper teeth, which we'll see quite often. There can also be drug-induced bruxism, or the clenching and grinding of the jaw, and also a preference for sweet foods has been noted. And again, this is kind of complicated by inconsistent oral hygiene practices and, given altered mental status during the duration of drug use. In terms of dental care for patients with a history of opioid use disorder, there are some studies to indicate that some patients may experience inadequate anesthesia or kind of report a phobia of needles, particularly at the hands of others. And this may further accentuate dental anxiety and kind of negative feelings towards dental treatment. So that is one thing for dental providers to be aware of. Also, it's important as dental providers that we carefully review medical histories. IV drug users are at higher risk for endocarditis, and it's important that these conditions are identified and managed appropriately in a dental setting. Switching gears a little bit, I wanted to talk about medication-assisted treatment. So as we know, methadone and buprenorphine are essential treatments for patients with opioid use disorders. However, they do pose risks for oral health. So methadone is dispensed as a liquid. Most formulations at this time do not contain sucrose, which is good. Buprenorphine is typically administered sublingually for absorption, but both methadone and buprenorphine are quite acidic in nature, which increases risk for cavities. So these are photos of application of buprenorphine containing strips. So the photo on the left is the sublingual administration. So patients are kind of instructed to put the film underneath their tongue and allow it to completely dissolve. Same thing for the buccal administration. Patients are instructed to put the film on the inside of their right or left cheek and allow it to completely dissolve. But the issue is that these strips are very acidic. Buprenorphine containing strips have a pH of 3.4 when dissolved in water. And patients are also specifically instructed to keep these films in their mouth and accumulate saliva to maximize absorption through the mucosal surfaces. However, that also increases the amount of time that this acidic environment is in the mouth, especially for patients if they're using these strips multiple times a day. So there's prolonged contact between teeth and the mouth. And this can be kind of similar to what we see for patients who are in active methamphetamine use. So this has led to the FDA putting out a warning in January of 2022, kind of finally acknowledging that there are some dental problems associated with buprenorphine medications dissolved in the mouth. And while it's important for healthcare professionals to know, obviously, the benefits of these products and these medications clearly outweigh the risks, there's some guidance that we can provide to patients to help mitigate the oral health risks of these medications. So for patients, I'd recommend after the medication is fully dissolved, take a large sip of water and just gently swish it around your mouth so that that acidic solution does not coat the teeth for more time after is necessary. Patients should also wait 1 hour before brushing. It seems a little bit counterintuitive, but we want to give the mouth enough time for the pH to buffer back up before doing another abrasive activity such as toothbrushing. For prescribers, prescribers should be, aware of these adverse dental effects and also realize that they have been reported in patients who have no history of dental problems prior to starting buprenorphine medications. So for prescribers, it would be good to ask patients about their oral health prior at the time of prescribing these buprenorphine medications, and also to counsel patients about the potential oral health problems and encourage them to see a dentist regularly. For dentists, it's important to perform, a baseline evaluation, caries risk assessment prior to comprehensive dental care. I just wanted to share briefly the study that was published in 2019 in Utah that followed the outcomes for patients in 2 recovery programs. One was called the First Step House, and the other one was called the Odyssey House. After establishing a unique collaboration with the University of Utah School of Dentistry. So patients, after about 1 to 2 months of residential substance use disorder treatment, patients were randomly assigned into a dental control group and a dental treatment group. And the results were very interesting. So in Figure A, we can see that the length of stay for the patients who were in the dental treatment group, and the dental treatment really involved comprehensive dental treatment that often involved, cleaning, extractions, fillings, and removable partial dentures if indicated. Patients in the treatment group stayed in treatment significantly longer than those who were in the dental control group, regardless of sex. And the same for regardless of sex, the percentage of patients who left treatment against recommendation was also significantly less than in the dental treatment groups, which are in green. And on the next slide, we can also see the study found an increase in employment at discharge was significantly higher in the dental treatment group than the dental control group. So 460% compared to 130% improvement. Increase in drug abstinence at discharge was significantly higher in the dental treatment group compared to the dental control group, 257% compared to 138%. And improvement in homelessness, 84% compared to 52%. So this study kind of demonstrates for one of the first times that integrated comprehensive oral health care can really increase the success of substance use disorder treatment as measured by factors that can be associated with long-term and long-lasting recovery. Switching gears just a little bit, I do want to touch on some oral health implications of HIV. This is especially relevant in our patient population. There was a study, I think, from the CDC in 2010 that estimated about 3.3% of the homeless population in the US was HIV positive, compared to just about 1% in the general population. So a quick chart just about the most commonly encountered HIV-related oral manifestations. This is worldwide. So this is from the 8th World Workshop for Oral Health and Disease. Okay, so oral health implications and effects of HIV are largely related to patients' compromised immune system. So studies estimate anywhere between about 32% to 60% of adult patients living with HIV have experienced at least one major oral manifestation of the disease. And in the absence of ART, sometimes or oftentimes oral manifestations can be the earliest significant indicator of an HIV infection. So the few that I'll talk about today are xerostomia, which we've already mentioned, dry mouth, candidiasis, oral hairy leukoplakia, gingivitis, periodontitis, and Kaposi sarcoma. So there's a significant increase in the prevalence of cavities and periodontal disease amongst patients who are living with HIV, and this can likely be at least partially attributed to increases in xerostomia or dry mouth. Because patients who are living with HIV and AIDS often have comorbidities, including cardiac disease, diabetes, mental health issues, and those medications often can induce xerostomia, including antidepressants, anxiolytics, diuretics, and antihistamines. So symptoms of xerostomia include the mouth dryness, very dry mouth, including inflammation of the tongue or glossitis, which you see in the top photo, and also kind of cracked surfaces on the lips and in the pale, dry buccal mucosa. Xerostomia can also lead to issues chewing food, tasting food, and can definitely increase risk for cavities and periodontal disease. Xerostomia also increases risk for opportunistic infections such as candidiasis, which we'll talk about. And for patients with xerostomia, really our recommendations are to increase water intake, to consider sugar-free gums or lozenges to stimulate saliva production, to use some salivary substitutes, or consider some therapeutic management with cholinergic agents. So candidiasis is really an opportunistic fungal infection that can be commonly seen in patients who are living with HIV or AIDS, caused by multiple Candida species. Can manifest as angular cheilitis in the corners of the mouth, which cause kind of painful crusting. Corners of the mouth that can bleed. Also, can be visible in the mouth as oral thrush or oral candidiasis, kind of these creamy white patches that are typically found kind of the oral pharynx, tonsil area, back of the throat, or also the buccal mucosas. So mild to moderate candidiasis can be treated with a topical antifungal, including nystatin, but severe infections can be treated with oral medications. Okay, next, oral hairy leukoplakia is a condition that is triggered by Epstein-Barr virus. It's most commonly seen for patients if their CD4 drops quite low, and it manifests as these kind of white patches on the lateral borders of the tongue. The condition itself is benign, so no treatment is needed, but counseling, and if smoking is a factor, smoking cessation is recommended in these cases. As I mentioned before, gingivitis and periodontitis are two oral manifestations also of HIV. There's one particular kind of gingivitis, linear gingival erythema, which you can see as examples in these photos, is the most common HIV-associated periodontal disease. There's also kind of an opportunistic component caused by Candida in this case. So for patients, particularly when it comes to periodontal health, the gingivitis and periodontitis, it's especially important for these patients to have kind of regular preventative hygiene visits with a dental provider. I'm going through just a little bit quickly. This is some examples of periodontitis. Kaposi sarcoma is a vascular malignancy. It's caused by herpes virus 8. Cases have rapidly declined in the US given increased use of ARTs. But these cases can still occur and should be referred to an oncologist for evaluation. But thankfully, ARTs have improved control and kind of preventing Kaposi sarcoma in the United States. So recommendations for dental care for patients living with HIV and AIDS. It's important to remember that these patients should visit their dentist regularly for dental appointments, every 6 months for an exam and cleaning. It's important to brush and floss teeth twice a day for about 2 minutes with a fluoridated toothpaste. It's important to always take HIV medication on schedule. To inform your doctor or dentist if your HIV medication is causing dry mouth, so that they can discuss the best treatment options for you, and to ask for a referral for a dentist if you do not have one. And recommendations for medical and dental providers is just to understand that really nearly all patients living with HIV are able to tolerate routine dental care, including procedures such as extractions and dental including extractions, but really care should be done on a case-by-case basis and in collaboration with the patient's medical provider. And sometimes there will be times where dentists will want to consult with patient's physician if there's concern for thrombocytopenia, if anything like oral surgery is planned. It's just a quick summary slide of what we talked about. And I'd like to just end by kind of, what can medical providers and patient advocates do for patients? And really, the first thing I would recommend is for medical providers to just consider doing an intraoral exam. I understand that oral exams are not typically taught outside of dental school, but really all they require is a pair of gloves. Tongue depressor is great, but just to take a quick look inside of the mouth. There's some great resources online. Oral cancer screenings are important. These are routinely done by dentists, but an intraoral exam provided by a medical provider can be referred to a dentist who can then do an oral cancer screening. The second thing is just to really encourage good oral hygiene practices, and this can be really done by medical providers or any patient advocate. So we encourage patients to brush with a soft or extra soft bristle toothbrush 2 times a day for 2 minutes with a fluoridated toothpaste. To floss at least once a day, preferably in the evening before brushing, and to limit sugary or carbonated drinks to a single sitting rather than kind of sipping throughout the day. And after you're done with that beverage, just swish your mouth with water afterwards. And these are kind of practices that can be used for all patients, whether they're in active use, whether in the neuroremission, or whether they have no substance use history at all. So I will finish there just in the, to be mindful of time, but we appreciate your time, and this is our contact information. We'd be happy to take any questions that you have.
Great. Thank you so much, Drs. Prasad and Rawlings Program. We really appreciate your presentation today. I will say that some questions did come in, but you guys did such a great job addressing it throughout the session. There was one question that just came in. Was leukolakia ever considered pre-malignant?
Oh, sorry. I'm sorry. What was the question? Is leukophakic ever considered pre-malignant?
Yes.
Yes, it can be considered. So really, we're looking for dental providers, we like to see a lesion and reevaluate in about 2 weeks. But erythroplakia lesions and leukoplakia lesions can be considered pre-malignant. That is true.
And so just opening up, are there any additional questions for the chat, for the Q&A, or if anyone wants to ask their questions live? In the meantime, I will just remind everyone, if you can please complete the evaluation. I actually did add it into the chat. We really would love your feedback. Great. We do have one question. So I'm going to open it up, Helene. Okay, Helene, you should be live now. Helene, you can unmute yourself. You want to ask your question?
Sorry about that. Thank you, Tara Samantha. You know I'm your biggest fans. This was excellent. The one question I have, other than my inability to unmute myself, is, with dentistry, as Tara was saying, so often it's that 2-week waiting period. We'll see you in 2 weeks, and if it resolves. My concern, and I'm wondering your comments on this, is with the increase in syphilis and congenital syphilis, that primary chancre could be gone in 2 weeks. So what might you recommend?
That's a great question. Realistically, sometimes we will have challenges, even with that 2-week kind of follow-up for our patients, just because they can, be quite transient, can be in the area this time, not in the area another time. I would say collaboration with a provider if they see the patient more regularly than we would. So if I'm seeing a patient today and I'm a little bit concerned, I'd like to see them ideally in a week, but if they no-show for that appointment, can I work with their primary care provider or another medical professional who's seeing that patient who can take a look to see, what is the presentation at this time? So potentially more use of teledentistry, which we've kind of dabbled in a little bit during COVID here. But I would say just a little bit more collaboration beyond just our dental clinic to try to capture patients if we're not able to physically see them in a week even.
Great, thank you. I don't see, Helene, did you have any additional questions?
Oh, I can always ask questions, right?
Well,
For those of you that know me, so if you prompt me on something I haven't talked about and want to talk about. No, this was excellent, and it's great to see the interprofessional on this because there's not quite enough of that. So any other suggestions you have for beyond STIs or substance use for interprofessional collaboration, or for the way, Tara and you, Samantha, work together? Go for it, ladies, doctors, however you want me to refer to you, colleagues.
great, thank you, Helene. So at this time, I don't see any additional questions. I will say that we did get a question about the CME requesting for the CEs. Just as a reminder, we do ask that you complete the evaluation. As you go through the evaluation, there will be a portion on the bottom where you can provide your information and request CME, CNE, social work CEs, or a certificate of attendance. So please complete the evaluation. So we do have one question. We can take that before we end at 2 p.m. As a case manager, how can we advocate to our dentists the importance of getting our clients? Dental services are very difficult in my area involving Medicaid.
I'd love to know, Donald, where you are, where you're from, and I definitely empathize with you. I understand that I'm fortunate to live and work in Massachusetts, where our Medicaid dental program is very robust. And I see Wilkes-Barre, Pennsylvania. Thank you. It is quite tough, and community health centers are a great place to start because they also have resources and professional collaboration. So I think community health centers that have a sliding scale fee, waiting lists are over 9 months for a new client. That is that like breaks my heart. It's very tough. I mean, even in Boston during COVID, health centers started having waiting lists for new patients. Community health centers are a place to start. Dental school programs can also be a resource for connecting to clinics in the area. But typically, community health centers just are a little bit more aware of, especially patients who have substance use disorders and kind of concurrent medical conditions. So I'm sorry that you are experiencing that. I would also check I'm sure you have already, but Pennsylvania's dental Medicaid website, because they may have some patient advocate groups or forums that you can help kind of connect to providers that may not be readily apparent so far. I hope that helps.
Great, thank you. So with that said, we once again want to thank you both so much, Dr. Rawlins-Pilgrim and Dr. Prasad, for that very informative session and topic that I feel is so important, and really I don't think there's enough being not enough sessions on this. I'm so glad that you can join us for our series to shed light on this. Just to let everyone know that our next session in the series is HIV harm reduction and youth engagement, and it will be on Friday, February 2nd at 12 p.m. Eastern time. Ashley has added the link to register in the chat. And if you have any questions, you can always feel free to reach out to us. So once again, thank you everybody for your time and for joining us. And we wish everyone a wonderful day, and we hope to see you next month. Thank you, everyone.